Good evening, all. I welcome you to the 23rd edition of TMC Meadowlarks today. And it is my pleasure to introduce Dr. Senthilnathan.M.S. He completed his MBBS in the 1992 batch, and he went on to pursue his MD in nuclear medicine at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And he is currently serving as a chief consultant in nuclear medicine at Jindal Institute of Medical Sciences, Hisar, where he leads the department and contributes significantly to high quality diagnostic services and patient care. We are delighted to have him today, and Sir would like to emphasize on the clinical applications and in of nuclear medicine for most of the specialities across the board. So I think with this, I ask Dr. Senthilnathan to go ahead and present his talk. And to the audience, some rules for the homekeeping or housekeeping. Kindly mute yourself upon entry so that it's easier for us to make a clear conversation and record the program as well. Thank you, sir. The floor is yours.
Thank you, Dr. Venkatesh. Good evening, everyone. It is an absolute privilege to be presenting in this forum, and I will be presenting some basic stuff only in nuclear medicine. And my apologies if any of the information which I am going to tell happens to be redundant for you. So nuclear medicine is a branch of medicine dealing with the application of unsealed radioisotopes or radiopharmaceuticals in the diagnosis and treatment of various diseases. Unsealed here I mean the radioactive materials can be transported from place to place with ease. In nuclear medicine, we deal with these three: alpha particles, beta particles, and gamma rays. Whether it is an alpha particle or a beta particle or a gamma ray, all take origin from the nucleus of an atom, whereas X-rays are extranuclear in origin. If we look at the properties of alpha particles, beta particles, and gamma rays, alpha particles are the most ionizing and the least penetrating. So since they are most ionizing, they can be used for therapy as a targeted therapy. Gamma rays, on the other hand, they are the most penetrating but least ionizing. So their linear energy transfer will be much less, and hence they are used for diagnostic studies. Beta is in between these two, but they are used for therapy. So if we look at the ideal characteristics of a radioisotope to be used in nuclear medicine, from a diagnostic point of view, if a radionuclide has pure gamma ray emission, that will be wonderful. And it should be having a short half-life, which will be ideal for diagnostic imaging studies. From the therapeutic point of view, either alpha particles or beta particles, and they have to be target-oriented. If we look at the diagnostic modalities in nuclear medicine, basically it is imaging only. First and foremost will be the gamma camera. Next is PET-CT, then is PET-MRI. Whether it is a gamma camera imaging or a PET-CT or PET-MRI, all are non-invasive, done as OP procedures. And the radioactive materials which are used in these, they are administered IV. Iodine-131, which is a commonly used therapeutic agent, it is administered orally. And these procedures are being radioactive, contraindicated in pregnancy. Let me start with gamma camera. This is how a gamma camera looks like. This is a dual head gamma camera. This is one head and this is the other head. This is a radiation detecting machine and not a radiation producing machine. So what we do, we administer the appropriate radioisotopes or radiopharmaceuticals intravenously. The patients will become a radioactive source, and those gamma rays emanating from inside the patient will hit the camera and produce an image. That's how it is done. So the most commonly used radioisotopes or pharmaceuticals are these. Technetium-99m, it is the most commonly used diagnostic imaging agent with the gamma camera. Iodine-131 emits both beta rays and gamma rays, and hence it can be used for therapy as well as for imaging. The pharmaceutical parts, the pharmaceuticals, we have umpteen pharmaceuticals for different organ systems. These are the most commonly used: DTPA, DMSA, ibuprofen, etc. DTPA, which stands for diethylene tripentastic acid, when it is tagged with like this. So the commonly used radioisotope is technetium-99M, depending upon the organ system to be imaged, we use different pharmaceuticals. Technetium-99M, when it is as pertechneted, when it is injected intravenously, it has its own biodistribution. But when it is tagged with either DTP or DMSA or MDP or mibrophenin, the biodistribution is determined by the pharmaceutical, not the radioisotope. So this is what we call the molybdenum generator. Molybdenum 99 is the parent compound of technetium 99M. This comes in this generator. Here what we do is there will be an inlet and there will be an outlet. Inside this, there will be an alumina column to which molybdenum 99 would have been adsorbed. So what happens is molybdenum 99 continuously keeps decaying to technetium 99M. So when we put some saline into the inlet, technetium comes out and that is collected in a vial. So the final preparation of technetium 99M will be in the form of a liquid. That's how it will be collected in a vial. And this is a DTPA pharmaceutical. This will be in a powdered form, lyophilized form. So once we tag, again the final preparation will be in the form of a liquid. And this is what we call the dose calibrator. We put this technetium DTP or technetium MDP or technetium DMSA, we put inside this dose calibrator, and that will show how much radioactivity is there. So depending upon the organ system to be read, the radioisotope or the radiopharmaceutical differs. The dose of the radioisotope or the radiopharmaceutical differs. Timing of the scan differs and duration of the scan differs. Clinical application using a gamma camera. So at the outset, I would like to tell that this is a functional imaging modality, not an anatomical imaging modality. We do see some anatomical details, but not to the extent of what we see in CT or MRI. Let me start with nephrourology. First and foremost is the radioisotope renogram, where we have both the glomerular regions as well as tubular regions. The most commonly, probably the only glomerular region which is used is the DTPA, diethylene triamine pentacetic acid, tagged with technetium 99M. Tubular region, MAC3, I don't think it is available in India because it is very costly. We use another tubular region called this EC, which stands for ethylene dicysteine. So depending upon what information we need to have, whether it is the GFR estimation or the EC clearance, we use the appropriate radiopharmaceutical. Procedure, how we do is, the patient will be on the couch, camera will be behind. The principle is that whichever organ to be imaged has to be kept as close to the camera as possible. So kidneys being retroperitoneal organs, we place the camera posteriorly and assume that, and it is a fact that we are seeing the patient from behind here. So this will be the right kidney, this will be the left kidney. So we inject it intravenously, take the perfusion images, followed by the parenchymal and excretory phase images over a period of time. Usually it will be around in the range of 25 to 30 minutes. And we make regions of interest around both the kidneys, draw the background regions of interest, and plot that in the form of a time activity curve and see what's happening inside the regions of interest. So this is the renogram curve. This initial portion will reflect the perfusion phase. This portion will reflect the uptake phase, followed which there is a downslope in the normal kidney. This will be the excretory phase. There is a big formula incorporated in the software which automatically gives the individual kidney GFR and the split renal function. Here, this is a normal functioning kidneys actually. So I will just tell the formula. The first and foremost is the percentage of the renal uptake percent as a percentage of the injected dose is calculated for the kidneys. This is the formula. The variables include right kidney counts, left kidney counts, background counts for both the left kidney and the right kidney, pre-injection and post-injection counts, and the right kidney and left kidney depths. This mu represents the linear attenuation coefficient, and this X represents the depth of the kidneys. This is the formula which we use for calculating the percentage uptake of the kidneys. So, as I told you, the gamma camera counts are calculated. It is measured from kidney regions of interest. What we have to do is, what the software automatically does is, the uptake at the 2 to 3 minute cortical uptake window is taken for calculation, because this is the time during which, at least in normally functioning kidneys, there is maximal glomerular filtration. Then after background subtraction, after depth correction, here it is given individually, the right kidney percentage uptake and left kidney percentage uptake. This is the formula. These are all counts derived. Next step is calculating the total GFR. An individual by name Gary Gates has devised this formula, which is a linear regression formula, where these two are the constants, and depending upon the percentage of kidneys uptake, the total GFR is calculated. What example is, say for example, if the right kidney uptake is 3% of the injected dose and the left kidney uptake is just 2% of the injected dose, the total GFR will be this much. It comes to this much. Split GFR is calculated by this. Right kidney is equal to total GFR into the right kidney percentage divided by the total kidney percentage. So the individual GFR we are getting it. Just we have to feed some data, height, weight, age of the patient, and the software automatically calculates and gives the individual kidney GFR and the split renal function. Here we can see these are all curves in a renal failure patient. The perfusion phase is there, but there is no uptake phase. You can see the upsloping segment is not there here. Because of renal failure, there is not much of radioisotope uptake is taken by both the kidneys, and these come out of the kidneys like this. These are typical renal failure curves. In the adult Indian population, normal GFR measured via this technetium DTPA gamma camera method is typically reported around 98.4 plus or minus 21.2 ml per minute, standardized to the normalized to the standard body surface area. And when I used to do these studies, I used to get a value of anywhere from 40 to 55 ml per minute for the patient's body surface area for the individual kidney, and this correlates fairly well with these values. This is the different in pediatric population. These are the GFR values in Indian children across ages from age 3.6 to 7.9 months, 7.9 to 12 months, and 18 to 24 months. The adult values are got by 2 years of age in pediatric patients. Here, this is another study where again we are seeing the patient from behind. This is the left kidney. This is the right kidney. Left kidney, we can see the uptake is quite normal and it is excreting normally. This curve. On the other hand, when we concentrate on the right kidney, the uptake is quite less, and that is hydronephrosis also. And here it goes on accumulating the tracer, and at 15th minute, the diuretic is given to see whether that is draining or not. This is an upsloping curve which turns out to a flat curve. A flat curve represents an equivocal obstruction, but since the function is less, which we can even tell visually, this patient needs to be surgically intervened. A slightly upsloping or a slightly downsloping curve will be an equivocal pattern, whereas a grossly upgoing curve will be an obstructive pattern. A downsloping curve like this will be a non-obstructive pattern. Next application is in diagnosing renovascular hypertension, where we know the pathophysiology, where in a patient with renovascular hypertension, the angiotensin 2 acts preferentially on the efferent arteriole, thereby constricting it, thereby the GFR will be maintained. Whereas in diagnosing renovascular hypertension, what we do is we give ACE inhibition, so this effect goes off. There will be a drop in the pressure inside the glomerulus, thereby the GFR will be reduced, the split function will be reduced, and the transit is also going to be delayed. If the drop in GFR is by 10 ml, if the drop in GFR is 10 ml per minute, at least, if the split renal function drops by at least 10%, and if there is a change in curve pattern, that will indicate a high probability for renovascular hypertension. High probability means it's more than 90%. Whereas if in case if the kinetics improve after ACE inhibition, that will represent a low probability for renovascular hypertension, which is less than 10%. Anything in between will be as bad as a non-diagnostic study. This is another patient where the right kidney has drained normally. On the left side, we can see some amount of some very minimal uptake in the region of the left kidney. It's almost a non-functioning kidney. A perfectly non-functioning kidney will not have any uptake at all. Here, we are seeing some activity, but it's practically it is a non-functioning kidney. From this, another thing what we can do is, of course, this is from an adult patient. See, we have got the required tracer activity in the bladder at the end of this dynamic study. Dynamic means where we keep on acquiring the images in a video format. In case if there is any gross VUR, what we do is we ask the patient to void and see whether there is any sudden appearance of activity in both sides. But this is a very crude method. High-grade reflexes can be easily founded by this method. This is what we call the indirect MCU. We do have the direct method also, which we call direct radionuclide cystourography. The advantage is that the radiation dose is around 20 times less than a conventional MCU. So follow-up studies can be easily performed. In the transplant evaluation, acute rejection, ATN, chronic rejection, and drug toxicity, we do have differentiating features like this, but at the same time, there are some overlapping features also. So at times it may be a bit problematic in diagnosing what it is. A renal biopsy, I think, would be the best option, but still, if there is an indication, we can assess the transplanted kidney also. So the advantages, individual kidney function, either GFR, when we use EC, that EC clearance, split function, and it is much more physiological because we are not putting an extra load in the form of iodine. This a system, a dilated system, which is obstructive on CTKUB need not be obstructive on this DTP or EC study. Next is technetium-99M DMS study. DMS stands for dimercaptosuccinic acid. What happens is this goes and gets fixed in the proximal tubules. So thereby it helps in delineating the renal cortical morphology. So here we can see again the posterior view, right kidney and the left kidney. Right kidney is fairly okay. Upper pole, there is a slight decrease in activity. Polar hyperactivity to this extent is a normal variant, but here it is looks a bit less. On the left kidney, we can see there is substantial decrease in tracer activity. If it is associated with volume loss, that will indicate scar. If there is only reduced tracer uptake without any volume loss, that will indicate acute pyelonephritis. So DMSA gives cortical integrity, functional renal mass, and the split renal function. But it will not give the GFR. It gives only the split renal function. What we do is we take the geometric means of the counts of both the kidneys and we calculate the split renal function. Coming to skeletal system, we use this technetium-99 labeled methylene diphosphonate. It is a measure of perfusion and osteoblastic activity. So wherever there is increased osteoblastic activity, those areas will be seen as areas of increased tracer uptake. If you look at the percentage of bone destruction to be needed for a lesion to be detected, with X-rays, 30 to 50% of bone destruction should be there. With CT, it is 10 to 20%. Bone scintigraphy, it is even less, 5 to 10%, which makes it a very sensitive modality in picking out the osteoblastic lesions. This is how a normal skeletal scintigraphy will look like, excreted by the kidneys. That's why we are seeing both the kidneys and the bladder activity. This is the injected site. This is a male patient with multiple osteoblastic metastasis. We can see multiple areas of increased and avid tracer uptake in a very, very irregular manner. So these are all osteoblastic metastasis actually. So if we look at the indications, metastatic evaluation, especially for CA prostate and CA breast, but after PET-CT has come into the picture, this indication has come down a lot. Then avascular necrosis, because we can diagnose that, because this is not going to get into the
Master, Alprax 0.25. அது 30 tablets. அவ்வளவுதான்.
then bone graft viability we can detect. Then unexplained bone pain is an indication. Unexplained elevated alkaline phosphatase will be an indication. Hepatobiliary system, we use technetium 99M labeled ibuprofen, which stands for bromotrimethyl immunodiazolic acid, which is an agent which is taken up by the hepatocytes, and it follows the path of bile. Only thing, it is not metabolized in the liver, and once it is into the gut, it does not undergo enterohepatic circulation. So these are the two common indications actually to differentiate extrahepatic biliary atresia versus neonatal hepatitis and bile leak. Here we can see the tracer has been injected, and we go on taking serial static anterior abdominal images up to a period of 24 hours if required. These two are the renal activity and the bladder. We are not seeing any tracer activity into the gut even by 24 hours. This is the picture which we get in a patient with biliary atresia. But the greatest advantage would be if we see activity in the gut significantly, that will straight away rule out extrahepatic biliary atresia. In neonatal hepatitis, at least by 24 hours, we should see some amount of activity within the gut. This is an example of a bile leak. Here we can see in the region of porta hepatis, there is some collection, and it is pulling down both the paracolic gutters. So this is a very, very sensitive modality, and we not even wait for a collection to build up. Even a few drops of bile coming out of its parietis can be easily picked up by this modality. Meckel's diverticulum, for this we use a technetium pertechnetate alone, and it has its own biodistribution. As I told you earlier, it goes to the salivary glands, it goes to the thyroid, and it is secreted by the gastric mucosa, whether in its normal position or ectopic. So this is how Meckel's diverticulum containing an ectopic gastric mucosa will look like. You see the stomach activity here because it is secreted by the gastric mucosa. Here there is an orthotopic secretion, thereby indicating the presence of ectopic gastric mucosa here. Meckel's diverticulum without ectopic gastric mucosa, we will not get a positive study. GE bleed, where we label the RBCs by means of this technetium pertechnetate. It can give the approximate site of bleed, and it is quite useful for intermittent bleeds also. It is not necessary that the patient needs to be bleeding at the time of giving the injection, as we see in CT angiography. So that becomes a great advantage. As long as the patient is under the camera, if there is bleed at any point of time, we can easily find out. Not only that, it is more sensitive. GE bleed in the rate of 0.05 to 0.2 ml per minute can be found out, whereas for CT angiography, it is slightly higher. The rate of bleeding should be 0.3 to 0.5 ml per minute. Usually the patients come to us after undergoing an upper GI endoscopy and colonoscopy. But here, in this particular patient, normally on the right side, we are not seeing any activity over here in the region of ascending colon, whereas in the region of descending colon, we are seeing some activity, which indicates the descending colonic bleed. That's how it looks like in a patient with GI bleed. Cardiac applications, mainly these two, to look for the presence or absence of inducible ischemia and myocardial viability. So for inducible ischemia, what we do is we stress the patient either by means of a physical stress or a pharmacological stress. A physical stress done either on a treadmill or on a bicycle ergometer, and at peak stress we give the appropriate radio tracer, and that will reflect the perfusion status at peak stress. Then what we do is, if it is in a single day protocol, 3 hours after the first injection, when the patient is taking rest, we give another injection, and that will reflect the perfusion status at rest. So we compare these two sets of images and come to a conclusion. If we look at the ischemic cascade in chronic stable angina, first and foremost event which occurs is flow heterogeneity between a stenosed and a non-stenosed vessel. At this level itself, we can find out inducible ischemia. Next one, what happens is wall motion abnormality, followed by a fixed perfusion defect, followed by ECG changes, followed by angina. So straight away, it reflects that this is a highly sensitive modality than even stress echo, but specificity is a bit less than stress echo because we do get some false positives at times, mainly because of some attenuation, diaphragmatic attenuation in female patients with breast attenuation. This is what I told you. Instead of stressing the patient, we can even give IV adenosine over a period of time because it is a potent coronary vasodilator. That will again reflect whether there is any heterogeneity in the flow between stenosed and a non-stenosed vessel. So plus or minus rest injection, because in case if the stress study or the adenosine study is perfectly normal, there is no need to go in for a rest study. We can stop with stress study itself, provided it is absolutely normal. So this is the mechanism. Whether we use system mostly, or at times we use this tetrophosphine. This is an agent which gets into the cardiac myocyte and sequestered in the mitochondria, and it stays there. This is how we we take tomographs of the heart. The computer does that. This is what we call a SPECT, single photon emission computer tomography. SPECT and PET are nothing but cross-sectional imaging in nuclear medicine. If it is done with a gamma camera, it is called SPECT. Positron emission tomography, as the name indicates, that involves positron emitters. So this is how the sections are made. This evaluates mainly the left ventricle. This will be the anterior wall, this will be the apex, and this will be the inferior wall. This is what we are seeing here. Here we can see, please concentrate here. The upper panel represents the perfusion status at peak stress, and the lower panel reflects the perfusion status at rest. We can see in the distal anterior wall and the apex, there is a grossly reduced blood flow, whereas it normalizes on a rest study. So this indicates inducible ischemia in LAD territory. So territory we can tell to what extent, whether it is a small defect or a moderate defect or a large defect, we can tell from this study. Myocardial viability. This combination of F8 and FDG PET rest study with SPECT rest study is the gold standard. Of course, late gadolinium enhancement contrast MRI in the heart also can be done. That is also very good, but I don't think expertise is widely available. So what we do is we do a spectral study. If it is perfectly normal, there is no need to go in for a PET study, FDG PET study. This is because the reason why we need to do this FDG PET study when spectral study is not normal is because of this. PET detects viability even when perfusion is severely reduced. SPECT may appear as a fixed defect but remains positive, but PET remains positive. So that's the difference between the SPECT. In SPECT, it may look like a scar, whereas if you do a FDG PET rest study, that can be positive, indicating that is hibernating myocardium and not a scar. Coming to thyroid, we again use this technetium pertechnetate alone. It is taken up into the thyroid gland by means of the sodium iodide symporter. This is how a normal thyroid scan will look like. This is an example of a Graves' disease. We can see both the lobes are symmetrically enlarged. Uptake is quite high, diffuse, and the background activity is reduced. So that's how a Graves' disease patient will look like. Subacute thyroiditis, due to destruction of the thyroid follicles by means of a viral infection, we are hardly seeing any activity here. So this is the picture which we get in a patient with subacute thyroiditis. Both Graves' disease and subacute thyroiditis are thyrotoxic conditions, but Graves' disease is a hyperthyroid condition, whereas subacute thyroiditis is not a hyperthyroid condition. Because the treatment is entirely different between these two, so that can be easily differentiated by means of doing this thyroid scan. This is a hyperfunctioning adenoma with almost complete suppression of rest of the thyroid gland. Say, for example, if you come across a patient with solitary thyroid nodule And if that patient happens to be thyrotoxic, there is every chance that this nodule could be a hyperfunctioning adenoma, which can be confirmed by means of doing this thyroid scintigraphy. And if it is like this, you need not subject the patient for an FNAC. This is because the chances of malignancy in a hot nodule or even a warm nodule I mean, and with normal uptake is virtually nil, less than 1%. Whereas if you come across a patient with cold nodule, the incidence of malignancy shoots up to 20%. So when to use thyroid scintigraphy? When the etiology of thyrotoxicosis is uncertain and when planning the patients for radioiodine therapy. So to differentiate various causes of thyrotoxicosis, we can assess the functional status of thyroid nodules and ectopic thyroid evaluation. Parathyroid adenoma we can find out. We use sestamib for this purpose. Technician will label sestamib. In parathyroid adenoma with some of the types will have an oxyphil rich content due to the differential washout kinetics from the thyroid gland and the parathyroid gland. In case if there is an adenoma, that will be retained for a much longer period of time. So if you have any doubt whether the patient is having a parathyroid adenoma or not, we can do this sestamib study and come to a conclusion. Not only detects this a normal positioned parathyroid gland adenoma, even an ectopic parathyroid adenoma can be founded by means of this procedure. This is the whole body iodine 131 scintigraphy in a patient who has undergone a thyroidectomy. Usually we do this study in a patient who has undergone a total or a near total thyroidectomy in differentiated CA thyroid patients. Say here the remnant will look like, depending upon the indication, whether it is a low risk patients, this scan is not needed. Whereas low to intermediate risk or intermediate to high risk or high risk patients, we have to do this scintigraphy to see whether there is any remnant tissue left behind after the surgery and whether there are any iodine-avid metastatic foci. This is how a thyroid remnant will look like. As I told earlier, iodine 131 can be both a beta emitter as well as a gamma emitter. Since it is a gamma emitter, it can be used for imaging, and since it is a beta emitter, it can be used for therapy. This is another patient, and that's how an ablated remnant should look like. This is a normal study because there is no iodine a bit foci here. Coming to PET CT, PET represents this positron emission tomography where we use, this is combined with the conventional CT. So compared with gamma camera studies, the radioisotopes are different here. The infrastructure is different here, and the indications are different. These are the four commonly used radioisotopes in positron emission tomography. The most commonly used is this F18, which has a half-life of 110 minutes. So what happens in gamma camera studies when we inject in gamma camera studies we use radioisotopes where with every radioactive decay there will be emission of a single photon. Whereas in positron emitters, what happens is once the positron is emitted from the nucleus of an atom, it combines with a nearby electron, annihilates, leading to the release of two gamma ray photons in exactly opposite directions to each other, and both need to be detected within a space. I mean, if they hit the we need to have a ring detector here, and if these two hit the camera within a specific period of time, that will be taken for counting, that taken as an indication that there is something abnormal out here in case if there is a tumor there. So we need to have a ring detector. It is a slightly higher energy level. The gamma rays which we come across in nuclear medicine, compared with radiation oncology, they are much lower energy rays. In nuclear medicine, these two are the highest energy rays which we come across in nuclear medicine. So we need to have a ring detector like this. This is how a PET CT scanner looks like. The CT component, this is the conventional CT scanner integrated with the PET scanner. The CT component is in the front and the PET component will be behind. So where is the need for CT while doing positron emission tomography? One is for the localization of the lesion, and second thing for quantification. because the CT can produce, can give absolute attenuation values. So they are used for quantification purpose. Not only that, the CT, it is a diagnostic CT, so it has its own intrinsic diagnostic value. So the information from the PET scanner, when combined with the CT scanner, will give a good idea about the disease status in the patient. This is a PET alone image taken at the level of one of the lumbar vertebrae. We are seeing some spots out here. Here there is one FDG. This is done with FDG, F18 FDG. We are seeing some spots here. We can see highly avid focus here and some amount of tracer uptake out here. But only thing, if we do a PET alone, we will not be in a position to localize from where it is coming. So this is the corresponding CT slice. So what we do is we fuse these two images together and see, now we get a fused image like this. Now I can tell very well that this abnormal focus is from the one of the lumbar vertebrae involving part of the pedicle and the right transverse process. These are all physiological activity. This is in the stomach and this is in the kidneys. F8 and FDG is excreted by the kidney. So we are seeing some amount of activity over here. So this is why PET scan is combined with the CT scan. PET-CT, if you look at its applications, 90% of its application is in oncology, and the most commonly used is F18 FDG. It is a marker for the tissue uptake of glucose. It is a radioactive analog of the normal glucose. The rationale is that most cancer cells exhibit increased glucose metabolism. So wherever there are cancer cells, they will be exhibiting increased glucose metabolism, and the injected FDG will be taken up in a much higher manner compared with rest of the tissues. So if we look at the difference between a normal cell and a tumor cell, we can see there is overexpression of these glucose transporters. So an increased amount of FDG gets into the cell, gets metabolized. The hexokinase is upregulated in a tumor cell, leading to the formation of FDG6 phosphate. Beyond that, it is not further metabolized and it is trapped inside the cell. Whereas the normal glucose, it is phosphorylated and it goes further down the glycolytic pathway. So that's the difference between an FDG and the normal glucose. FDG is trapped inside a tumor cell in a much the uptake is going to be higher, and that we can see as areas of hotspots in the image. So here is what happens between a normal cell and a cancer cell. We can see there is intracellular glucose is much higher in a cancer cell. So FDG comes in the form of a liquid form like this, a clear liquid. It is injected intravenously. The scanning to be done after 45 minutes, and CT with or without contrast precedes the PET imaging. So PET-CT combines the metabolic information. This is from FDG. Combines the metabolic information and the anatomical information, and usually metabolic changes precede the anatomical changes. So that makes it a very, very sensitive modality again. Here we can see in a patient with lymphoma, here we can see this is the spleen. That is one focus which we are seeing in the spleen here, which is clear on the fused image, whereas the CT is absolutely normal. So that it can make a big difference actually, doing the PET scan combined with the CT scan. CT is normal here, but there were umpteen other lesions which were positive on CT as well in this patient, but here there was one lesion which showed pathology only in the PET image and not in the CT image. So we measure this, how much it is taken up by means of this formula, what we call the standardized uptake value. This is given by this formula. This is a ratio and it does not have a unit. To put it in another way, suppose if we inject FDG and if we assume uniform concentration across the body, and if the level of activity is at if the normal focus is 1, and we can tell how to what extent whether how much intense it is, we can quantify by means of this standardized uptake value, some 2, 3, whatever we get depending upon the FDG avidity. So this is the normal biodistribution of FDG. we can see much activity in the brain, very high activity in the brain, because this uses glucose to a great extent. Evaluation of brain lesions may be a bit problematic in PET image. And these are all some normal tracer uptake only, lingual tonsil, palatal tonsil. This cardiac activity is highly variable depending upon the level of fasting and the level of endogenous insulin. And it is excreted by the kidneys. That's why we are seeing an activity in both the kidneys and the urinary bladder. This is how a normal biodistribution of F18 FDG would look like. This is another patient. Do I need to tell whether this is a normal or an abnormal study? This is a grossly abnormal study showing the supra and infradiaphragmatic lymphadenopathy. This is again a patient with lymphoma. So if we come to the clinical applications of PET-CT, first and foremost would be the staging of known cancers. Response assessment, we can easily differentiate whether there is a residual tumor or whether there is just post-treatment fibrosis. Unknown primary, again, it's helpful. Say, for example, we do come across patients with a neck node, hard neck node, when they do an FNAC, that turns out to be a metastatic squamous cell carcinoma. They will do all investigations, still unable to find a primary. So since we can, FDG is an indication for that, because somewhere it's going to show up. We can differentiate benign versus malignant lesions. In general, the higher the activity, the more it is in favor of malignancy. Tumor recurrence, again, we can find out. It aids in taking a biopsy also, because there can be necrotic areas, heterogeneity of the tumor. Wherever there is active FDG uptake, from that portion, if we take a biopsy, that will be much more meaningful. This is another patient with CA esophagus. We can see the activity in the mid-thoracic esophagus. This is the injection site. Here, this is the bladder activity, renal activity, everything is normal. But here we are seeing one FDG with focus. The importance of PET-CT comes because in this patient, if this portion had not been covered, this lesion would have been easily missed. So that's the greatest advantage. Another advantage is that it is a whole body evaluation. We normally take from vertex to mid-thigh. This lesion was localized to the left iliac bone. Though the CT showed a lytic lesion, FDG avid focus is there. It is now being treated as a metastatic focus. If this PET-CT had not been done, whole body evaluation had not been done, this lesion would have been easily missed. This is a patient with CA gallbladder. We are seeing intense FDG avid focus in the gallbladder. These are all reactive nodes actually. And there was a large, this is a biopsy proven case, adenocarcinoma grade 2. And there was a nodule in the left lobe of thyroid, which is seen as some 2 or 3 foci of FDG avidity. Patient, this is again a recent patient. I do not know what happened to this lesion. Another patient with NHL showing the supra and infradiaphragmatic lymphadenopathy. Same patient, post 6 cycles of chemotherapy, everything has vanished. This is a patient with a mediastinal tumor. Anterior mediastinal tumor on cross-sectional imaging turned out to be diffuse large B-cell lymphoma on IHC. So if we come to the specific indications for FDG PET-CT in oncology, so this is a partial list of the cancers. For head and neck cancer, say for example, if there is only a T1 lesion or a T2 lesion, if whether FDG PET-CT is indicated or not. So like that, if we see across the individual cancers, for head and neck cancer, if it is locally advanced, then only FDG PET-CT becomes an indication. Lung cancer, from initial staging, it is important, FDG PET-CT. Esophageal cancer, I showed you one case. So in the initial evaluation, to look for any distant metastatic focus, because literature review indicates that in roughly 15 to 20% of the patients with esophageal cancer, there can be distant metastatic foci and leads to the change in the management in those patients. Gastric cancer, roughly 50% of the gastric cancers are not FDG aware. So depending upon the histology only, the patients need to be subjected for FDG PET-CT in gastric cancer. This mucinous adenocarcinoma, signet ring cell types, they don't take up FDG much. Breast cancer, again, stage migration is very, very important. Stage migration, I mean, compared with conventional imaging modalities, there occurs in a significant number of patients, upstaging happens from 1 to 2, 2 to 3, and 3 to 4 stages. The indication will be from stage 2B. So whatever that means, the oncologists know it better than me. The staging, the individual staging for gynecological cancers, cervical and endometrial cancer. When we suspect distant metastasis, that is an indication. For ovarian cancer, it is very specific for to look for the presence or absence of recurrence when there is an elevated tumor marker with equivocal or negative CT or MRI. Lymphomas, for baseline staging, it is important. Interim assessment post therapy, that also can be done, and the end of treatment response also, that's an indication. For sarcoma, for high grade sarcomas, it is quite helpful. So these are instances where FDG PET-CT is not that much helpful. One is well differentiated hepatocellular carcinoma, because it contains a lot of glucose 6 phosphatase. So the FDG is not going to be trapped as compared with the rest of the tumors. Minimally invasive. So whichever tumors show low glycolytic activity, those things won't be that much helpful with FDG PET-CT. Indolent prostate cancer, we use PSMA, prostate specific membrane antigen PET-CT. Well differentiated neuroendocrine tumors, where we use gallium-68 dotatate. These are some of the other cancers where it is not that much helpful. If you look at the tumor features, necrotic tumors, again, FDG is not going to get in there. Low-grade indolent tumors, tumors with mucinous features, and lesions smaller than the resolution of the PET scanner. The resolution is up to 5 millimeter. Any lesion less than 5 millimeter, it will be difficult to detect by means of this conventional FDG PET-CT. Limitations of PET: we can get false positive lesions. Some benign lesions can show up, inflammatory lesions can show up, infection can show up. So most of the patients are referred for FDG PET-CT when they have a tissue diagnosis already. So that will reduce the confounding factors. Lesion should be at least 5 millimeter, but it is not helpful for T staging. PSMA PET, which stands for prostate specific membrane antigen PET-CT, it is initially it was thought that it was specific to prostate, but not anymore. All these organs do take up this prostate specific membrane antigen, or it is expressed actually. This is basically a transmembrane glycoprotein. So we use this PSMA ligands, PSMA 11, PSMA 617, labeled with either gallium-68 or F18. So they are in prostate cancer compared with normal prostate gland. This PSMA expression is very high, somewhere in the range of 100 to 1000 times. So those areas will be seen as areas of PSMA avidity, and this is internalized, and again it is inside the cell. So this is you can see this is a F18 PSMA study. The distribution is different than FDG. So because all the reasons, the slide which I showed now, these organs are taking up this PSMA. This is a normal individual where we are not seeing any pathologic foci. Here, this is one patient with CA prostate. This faint activity is the bladder activity, whereas the avid focus is the CA prostate expressing, overexpressing, indicating the presence of CA prostate. These are the pelvic node, metastatic pelvic nodes. PSMA PET-CT is more sensitive in nodal staging as compared to MRI and abdominal contrast enhanced computer tomography. And not only that, since we are doing a whole body evaluation, something somewhere again can be found out. This dotatate, again, it is this DOTA is a ligand gallium, labeled with gallium-68. This is basically for neuroendocrine tumors, for grade 1 and grade 2 neuroendocrine tumors. If the neuroendocrine tumor exhibits grade 3 or if it is a neuroendocrine carcinoma, we have to do an FDG PET CT study. That's again the normal biodistribution of the gallium-68 dotatate. Compared with conventional imaging, it leads to a change in management in around 40 to 60% of the patients doing the scan. Again, these are the reasons for the physiological biodistribution of this gallium-68 dotatate. Neurology in evaluation of dementias and movement disorders. These two are from different patients. This one is the 64-year-old male who came for an oncological indication. This patient was a patient with known frontotemporal dementia with pyrexia of unknown origin. That's why this patient was referred for a FDG PET CT study. We can see compared with the rest of the brain parenchyma seen in the frontal lobe, the uptake is quite less. So this is because of the dementia. PUO, we did not find any other focus of abnormality in this patient. So these are the differentiating features between Alzheimer's, frontotemporal dementia, diffuse Lewy body disease, posterior cortical atrophy, and various types of primary progressive aphasia. So it detects early disease and excellent subtype differentiation. Best use is when the clinical picture is atypical or MRI is normal or equivocal or in early or mild cognitive impairment. That can be done. This fluorodopa dihydroxyphenyl labeled with F18 for differentiating Parkinson's disease. We can see this is a normal patient. We can see the caudate nucleus and putamen taking up normal activity. It is bilateral and symmetrical, whereas we can see in the putamen there is grossly reduced uptake of this dopa in a patient with Parkinson's disease. So that differentiates neurodegenerative versus non-degenerative mimics. Early Parkinson's disease, it is helpful, and when there are atypical clinical presentations. PET MRI, where instead of CT, the machine will have an integrated PET scanner as well as an MRI scanner. But PET MRI is not universally better than PET CT. It is superior only when MRI is intrinsically superior to CT for the organ system in question, and when PET adds complementary information. Having said that, it's still for most of the solid cancers, the first hybrid imaging modality is PET CT and not PET MRI. Radionuclide therapy we give for hyperthyroidism, whether it is Graves or toxic adenoma or toxic multinodular goiter with iodine 131. When antithyroid drugs fail, differentiated CA thyroid in a post-surgical scenario, I will show in the next slide. Bone pain palliation in patients, especially in patients with CA prostate and CA breast, we use phosphorus 32, strontium 89, samarium 153. When every other modality of pain relief has not given relief to the patient. So this is in patients with a differentiated CA thyroid in a post-surgical scenario, depending upon the estimated risk of structural recurrence, we categorize these patients into low risk, low to intermediate to high, and high risk patients. Low risk patients do not need subsequent iodine 131 therapy. Low to intermediate and intermediate to high risk patients, iodine 131, high dose iodine 131 therapy needs to be considered. For high risk patients, it is indicated. Then in patients with CA prostate, metastatic castration resistant prostate cancer, we label this PSMA with this lutetium 177, which emits both beta and gamma rays, so it's helpful for therapy. These are the indications actually. Patients with PSMA, they have to be first positive on a PSMA study and who progressed under at least one novel androgen axis drug and at least one taxane regimen and under unfit for or refuse a second taxane regimen. And patients with PSMA positive metastatic castration resistant prostate cancer who progressed under at least one novel androgen axis drug and docetaxel, but still would be possible candidates to receive cabazitaxel. Patients with PSMA positive but taxane naive castration resistant prostate cancer who progressed at least one novel androgen axis drug. I do not have any hands-on experience in treating these patients. This is the usual dose, 200 millicurie every 6 weeks for a maximum of 6 cycles. For neuroendocrine tumors, grade 1 and grade 2, they have to be positive on the study should be positive in a DOTA study or similar DOTA. Other agents are also there, DOTA-TEC, DOTA-NOC, and who has progressed with the long-standing somatostatin analogs. And it is primarily used for gastroenteropancreatic neuroendocrine tumors, but can be considered for other well-differentiated somatostatin expressing positive neuroendocrine tumors. So this is the usual dose, 150 to 200 millicurie, 3 to 5 cycles every 6 to 12 weeks. That's all I have for you. Thank you.
Thank you, sir. That was an excellent overview of the different aspects, very briefly done. And system-wise, you have given an elaborate view of how to go about radionuclide studies. So to set the ball rolling, I have a couple of questions.
Okay.
In the nephrology world, we often use DTPA or DMSA. But MAC3, as you said, is not available in India and it's very expensive. And are there any alternates for the tubular agents? Sometimes I find the DMSA scans are not very well done, and especially when it comes to scarring or size of the kidneys, especially in advanced renal failure. As you know that in most of our donor evaluation, we use DTPA. But sometimes suspicion of scarring, we want to use DMSA. And is DMSA useful when the kidney functions are very low? To cut a long story short, that's the question I wanted to ask. DMSA is useful only when kidney functions are normal, or is it useful even when the GFR is extremely low?
I can tell for DTPA, if the creatinine, it holds good up to a value of 2.5 to 3 with DTPA. With EC, it is up to the range of 5 to 6 creatinine. And with the DMSA, in renal failure patients, the background activity is going to be much higher, and that will confirm the picture. But I am not sure about till what creatinine values DMSA can be done. I am not very sure about that.
Because it's a proximal tubularly secreted drug, and in advanced
Yes.
renal failure, kidneys are contracted. So
Yeah.
those are the cases where we actually want to look at the scarring. But if the GFR is very low, MAC3 probably is a better choice, isn't it?
No, the thing is that tubular agent you are telling DMSA with DMSA, this is an agent which is going to be fixed at the proximal convoluted tubules, whereas MAC3 is a transit agent. So
Okay.
that distinction is important. So out of the two, I would still prefer doing a DMSA study if I mean, of course, for scarring, we have to do a DMSA only. MAC3 will not help because that is a tracer which is going to be in transit. This DMSA is going to get fixed at the proximal tubules, actually.
So if you want to study effective plasma renal flow, which one would be preferable, sir?
Yeah, effective renal plasma flow, DMSA is not helpful because this is
Okay.
going to get fixed at the proximal convoluted tubules.
So MAC3 will be useful in that.
Yes. MAC3 or even EC, which I told.
Yes.
EC is widely used in India.
Okay. Okay. So the next question is, as physicians, one of the common problems that we face is fever of unknown origin. So
Okay.
you covered extensively about cancer, but when it comes to infection, ordering for a PET-CT is kind of standard these days. Even for patients who have been having fever for a short duration, I find PET-CT being used left, right, and center. So
Okay.
is PET-CT really a good modality of choice for diagnosing infectious causes for fever of unknown origin?
Of course, yes. The thing is that something somewhere we can pick out, but what it is, we may not be in a position to tell. But it will localize the disease if it is going to be there. You can put a needle and come to your tissue diagnosis.
Okay, so even infections, PET-CT is very useful when compared to malignancies alone.
Specifically for PUO.
Okay. So if there are any further questions from the audience, please go ahead. Any questions or comments?
Hello, hi. I'm Murugesh Vengi.
Go ahead, sir.
Yeah, Senthilnathan, it was a very nice presentation
Thanks,
and
Murali.
quite extensive. When started with the basics and gave us our no, school days, gold leaf
Yeah.
experiment, J.J. Thomson, alpha particle, all those things. It
Yeah.
was very had a good insight as well as the positron emission, annihilation, and then you have a photon emission. All those no detailed explanation. It's very elaborate. I would have appreciated if many undergraduates and PGs joined in it. This would have remember those days when we have MCQs. All this we
Yeah.
just mug up all these things from
Yeah.
experts. Said if they attend this very insightful meetings, it will be very revealing to them. Unfortunately, this usually been the case all along. Those who real benefactors, they are not attending. Uh,
Mm.
the same thing, Vengi just asked the question I was about to ask. No, earlier we used to have this white cell technetium scan for
Yeah.
any PEO or no undiagnosed. And now, like Vengi mentioned, everybody has moved to PET scan. And
Mm.
do you find, is there any advantage in the earlier white cell scan? That is technetium scan, I think, technetium labeled. And
Gallium or chromium labeled scans, I think.
yeah, and compared to that, PET scan, is it superior? That's my query.
Of,
Thanks,
of
Sandra.
of course, PET scan is superior, but it is not as specific as doing the WBC labeling. But the problem with WBC labeling is that it is a very cumbersome procedure. The labeling itself takes 2 hours, not practiced in the vast majority of the centers in India. And that too after the advent of PET CT, I don't think it is being used anywhere, in India at least. Second
Yeah,
thing, second thing,
yeah,
the lesion size. With the technetium agents with the gamma camera, for a lesion to be picked up as a hotspot, the size of the lesion should be at least 8 millimeter. Whereas in PET CT, it drops down to 5. I mean, it drops down to 5. Even 5 millimeter lesions can be picked up. Second thing, it is a whole body evaluation. Of course, technetium also can be, we can do a sort of a whole body, but definitely PET CT is superior, though it is not specific. But it will localize the
yeah,
problematic focus. Again, you can put a needle and come to a conclusion.
yeah. Thanks,
Uh,
Sandra. And it was, yeah, quite useful. Yeah.
Thank you.
One more question, sir. In patients with advanced renal failure with
Hmm.
secondary hyperparathyroidism versus tertiary hyperparathyroidism, that is when they have an autonomous adenoma in the parathyroid gland, often we find that reporting becomes difficult when you have diffuse parathyroid hyperplasia versus parathyroid adenoma. How do you actually differentiate these two entities? Because in secondary hyperparathyroidism, all the four glands are hyperplastic, whereas
Yes.
in tertiary, it is adenomatous. So how do you essentially differentiate between the two?
Parathyroid adenoma usually, primary hyperparathyroidism, usually we see only one gland, or at the maximum I have only two glands. In parathyroid hyperplasia, all the four glands will be visualized.
I'm talking about tertiary. So tertiary hyperparathyroidism is adenomatous transformation of a pre-existing parathyroid hyperplasia in renal failure. So they have secondary hyperparathyroidism in renal failure, but after over a period of time, the parathyroid glands escape the regulatory control and they become autonomous. So they become nodules. So you have a situation where four glands are hyperplastic, one of them become autonomous. Then
Okay.
diagnosing this becomes very difficult whenever you are ordering a system EB scan.
No, from system scan, it will be difficult to, looking at the scan alone, it will be difficult to differentiate. We can only tell the presence or absence of an adenoma. That's
Mm.
how this primary or secondary or hyperplasia, of course, we can make a difference. Whether it is tertiary adenomatous transformation, it will be difficult. You have to fall back on clinical picture only.
Okay. I think there are no further questions or comments from the sparse audience who have attended. But
Okay.
as expected, I think today was some other meetings going on. I think a lot of people might be engaged in that. But we'll
Okay.
continue to have a session too on targeted systems, sir,
Okay.
especially. So I think in the future we'll have one more session on this that might be useful. I think that I will put up the recording of this as early as possible. And we have this YouTube site called TM's Medalogs. So
Okay.
I keep uploading the videos, and that will be useful for everybody. Thank you, sir. Thank you so much for having given
Thank
your
you.
expertise and your time. And it was a phenomenal talk. It covered just about everything. If anybody wants to know the basics of radionuclide the therapies or diagnostics in clinical practice, I think this would be a useful primer. Thank you. Thank you all for attending. I think with that, we'll call this a day.
Thank you, Dr. Venkatesh.
Thank
Thanks
you.
for the opportunity.
Thank you,
Thank you,
Senthilnathan.
Murugesh.
Thank you.
Thank you,
Thank you,
Murugesh.
Venki, for the nice
Thank you.
presentation.
Thank you.
Probably it's India South Africa match. I think everybody has gone
Yeah.
back to that. that might be
Possible.
a reason as well. Yeah.
Yeah.
Thank you. Thank you.
Thank
Thank you.
you.
Thank you. Thank you.